All right. Well, thank you everybody for being here. I am sorry for that technical glitch there. We're just trying to get started and it sounds like we are on. Welcome so much and thank you so much for coming to our meeting today. I appreciate that. We have a very special guest and she's special for many reasons, but I think the reason why for us as a district that she is so special is that she is one of our parents of children in our district. And we really appreciate her medical expertise and her knowledge and just being able to be a resource, not only to us as a district, but to our community as a greater system, to many different organizational institutions to provide that guidance and input on the latest information regarding COVID-19 and how we can best be responsible in responding appropriately and maintaining a safe school environment for our students so that they can stay in school as long as possible. So I'm going to turn it over to Dr. Lynn Fitzgibbons. I've given her some things to share, but we will also open up Q&A so that we can have an opportunity to address questions, but we'll go ahead and let her get started so that we can go ahead and cover some content over the next 45 minutes. I do want to say that we are going to record this meeting and we are also going to make sure that we have an opportunity to have it translated with Spanish subtitles so that we can make it available on our website and also share it with parents via Parent Square so our families who need the information in Spanish can access it. So we're real happy to be able to provide that as well. So Lynn, it's over to you.
Thank you so much. Thanks for the chance to connect with you all today and happy first week of school. The goal here, I think, is to perhaps in a very practical way review some of the information that's available. And one of the goals that we had was to make sure that part of what I did today was actually show you how I use some of the tools and the resources that are available to all of us. We'll hope to answer some questions today, but we'll also, I think, hope to show you where the tools are for you to continue to answer questions as they arise. And so with that said, I'm going to go ahead and share my screen. And Diana, can I just confirm that you can see my screen? Yeah. So
yes, we can see it. Thank you.
That's great. Thank you. So this is the community data dashboard, which some of you may use frequently, some of you may not have visited, but I wanted to make sure that everyone understood what some of the great functionalities of this amazing effort are. So places to land. This is the very first page. This is called the summary tab. And here within the data dashboard is where we can see the most recent cases and we can see some important trends. I'm just going to show you over here. We can see just a snapshot. Yesterday there were 71 new cases. Right now we have 800 active cases. And here are some cumulative data. Here's our current case rate, percent positivity, and again, cumulative deaths across the county, the number hospitalized, which I'll show you, I tend to take a deeper dive into, and then any new deaths reported. And so here in the top right corner, there's a four-pronged arrow that you can select for any one of these. And here again, we see the differential, for example, between the county's average daily case rate here in gray, right up through 2 weeks ago, and then also broken out the case rate in those who are unvaccinated in our county compared to those who are vaccinated. And so again, just one example of the charts that are available to us. We also can see that data broken down by not case rates. Remember, rates are how many per 100,000 Santa Barbara County residents, but actually simply the number. And here is simply the number, the daily case count. And we see in orange those who are unvaccinated, and in blue or teal, those who are vaccinated. And again, the challenge, the sadness, the big perhaps missed opportunity that I think we may be seeing here is, of course, that we're seeing, unfortunately, the Delta variant, the cause of our current surge, really disproportionately impacting our community members who are unvaccinated. But we are seeing, and this is a second important part of the story, we are seeing these breakthrough cases in vaccinated folks too. The good news, of course, is that the vast majority of the breakthrough cases are not being seen in the hospitals. They're not causing severe disease, but rather they're, simply causing either asymptomatic or mild disease. Certainly wish that that wasn't the case. The good news is the vaccines are still providing really good protection, but clearly not absolutely perfect. And so then we can go down and we can actually, again, look at recent cases from July. This is total, not broken down by vaccines. But in here, you see the difference between the episode date and the report date. If I was diagnosed with COVID 4 days ago, I might have been swabbed 4 days ago, and that was my episode date, but my doctor might not get that report until 2 days ago, and then maybe his office staff put in the report yesterday. And so it would be reported from yesterday, that's the report date, but actually the day that they tested me, the day that I was swabbed, the episode was actually 3 or 4 days ago. And so that's the difference here between these two different numbers. And this is the most recent 4 weeks, but then of course we can do cases and look at the pandemic as a whole. I promise not to spend too much more time on the dashboard, but I do want to just show there's such great functionality here. Of course, here we see the big winter surge, and here we see this Delta surge that we're experiencing right now. You can pull this toggle, this is up here, top left. You can pull this toggle and actually change your x-axis. So you could really drill down. Let's say you were most interested in what's happened since May 24th. Here you can see those lovely days of May and June. And then unfortunately, early July, we started to have our case rates increase. So again, that's all on the summary page. You can also see more information on vaccines. And again, you can open any of these up, as well as variants. So let me just expand the variant surveillance information. Santa Barbara County's variant sequencing has been much more expansive over the last 8 months than ever before. In fact, we had very few variant sequencing tests. And here, what I mean is, it's one thing to get a test and to confirm that someone has COVID or doesn't have COVID. But of course, there are different versions of the virus, what we call variants, that we have learned now a lot about and have been increasingly important to track. And so in February of this year, I actually started a meeting called the Local Variant Task Team with representatives from Cottage Health, from Marion Regional Medical Center, from the Public Health Department, from UC Santa Barbara virology specialists, and then from all of our labs. And we kind of got together, and we've been meeting now every couple of weeks, in fact, every 2 weeks on a Friday afternoon, and looking at our local variant results. And we did a big research project, actually, which has supplied a lot of information. But also the good news is, in the background to that, our local public health and state public health variant surveillance testing has also really increased. And so what that means is we actually know a lot more now than we've ever known about what variants have been spreading through our community. Back in October of last year, I can tell you exactly what we found when we sampled these. We actually took them out of the freezer from months before and sequenced them to make sure that there was no Delta, that there was no Alpha, for example. And sure enough, there were the variants that we saw were the variants that we expected to see back then. And then in this kind of peach color, what we see is the introduction of the West Coast variant. And it kind of appeared in November. It was really to blame for most of our winter surge in January, February, and then it kind of disappeared. And part of the reason it disappeared was that Alpha showed up. Alpha is this slightly rusty orange color. And Alpha, of course, is the UK variant or the Kent strain, B.1.1.7. And so what was interesting is as the West Coast variant melted away, the UK variant came. But then the UK variant has disappeared. And the reason it has disappeared is showing up on this graph really clearly. It's because Delta showed up on the scene. The Delta variant really appeared in our community in mid-late June, and by July has just absolutely replaced all other variants. We still have a very small number of the P1 variant. This is the variant from Brazil, which is hanging around. Perhaps, one of its skill sets is that it might be able to evade the immune system a little bit, what we call immune evasion. So maybe it has a tiny advantage in that, people who previously were infected or vaccinated may be slightly vulnerable to this gamma variant. Nevertheless, it has nothing like the advantages and really the superpowers of the Delta variant. And what are those superpowers? Why is the Delta variant really getting such a strong hold on our communities and causing such a devastating surge across the country, across the world? It's because it's so infectious. And so we really have seen the Delta variant, again, just in our own community over 6-7 weeks show up and then just dominate now with, 95% of all of our cases, the Delta variant. And so, again, all this information excuse me, is available for anyone who wants to take a deeper dive. You can go along the top here and look at any number of, topic. You can look into vaccination rates. You can actually look at vaccination rates around our county. You can see summary information, and then you can, again, see different vaccinations by age. You can see different vaccinations by region. I'm sorry, my computer is not moving very quickly. But I think all this to say that the community data dashboard is just a very, very rich amount of information for anyone who's interested in this. So, here's the vaccines by region, for example. Here's vaccinations by age. So very, very interesting information there. Diana, was there anything else that, I know we wanted to make this a little bit more conversational and then I just jumped in and started talking, but was there anything else about the community data dashboard that you wanted to make sure that we covered?
No, I think that this is really helpful. I think sometimes this dashboard can feel a little overwhelming to your, standard layperson who doesn't have a medical background and experience. So I appreciate you just modeling for us. Being able to keep up on, especially that graph that shows the difference between the vaccinated and the unvaccinated and the daily case rates. Those are really helpful. And then just being able to monitor how we're improving as a county with regards to our overall vaccination rate is super helpful. So I think that's great. Thank you for that. We did have a question, and I'm wondering too about the variants, because as we've seen the variants come and go and change and be replaced with new variants, is there any concern that over time that the actual vaccination that we've all had will no longer be as effective so that it does, I guess, prevent serious illness or hospitalization? Do we anticipate that there could be a cause for a booster or a change in vaccination? What's the thinking right now on that?
Thanks. So great question. And of course, the answer changed in the last 12 hours or 10 hours. So just to remind everyone, you're fully vaccinated if you've had 2 doses of the Pfizer vaccine, the Moderna vaccine, or 1 dose of the Johnson & Johnson vaccine. What we know, though, is that these vaccines don't provide indefinite, long-term, forever protection. And what we're seeing as we study communities, countries, and different groups' experiences with the vaccines is that the antibody levels are decreasing over a number of months. We also know, and this seems like a straightforward correlation, but I was waiting for some data to really support this, and it's kind of come forth. We also know that if your antibody levels are lower, then you are, at more risk of a breakthrough infection, which again, it makes logical sense, and we would all expect that to be the case. But the good news is I think we're now actually seeing some data to say that's the case. So what happened, I think most importantly, was about 2 months ago, about 7 or 8 weeks ago, there was a study published that showed that solid organ transplant patients who had themselves received 2 doses of vaccine but had not made antibodies, a group of them were given a 3rd dose, a booster dose, in a clinical trial. And what was shown is that a good number of them actually then started making antibodies. And it seemed to be the case that it was very safe. They did well with it. And what this really indicated was that for these solid organ transplant patients with weak immune systems, 2 doses wasn't enough, but 3 looked like it was going to be better. And then in the wake of this, there was more kind of more publication, more interest in, again, immunocompromised people, and were there other groups for whom this would be true. All this led to last Thursday's and Friday's meetings and review by the CDC and the ACIP group. And then, of course, a recommendation came on Thursday and Friday last week, and the change happened over the weekend with the EUA for the vaccines, where now immunocompromised patients, and you have to be fairly immunocompromised. There's a good list on the EUA now. But the immunocompromised patients who've received 2 doses of mRNA vaccine can be offered a third, and it's actually recommended that they go ahead and get one. And so this is really important because this was the first booster recommendation. It came out last Friday. And then, 10 hours ago, literally late yesterday evening, we learned that the federal government is actually looking at potentially recommending a more global booster approach across the country in a more really global way, with the break of who gets it to who doesn't get it, not related to age, as has been done in other countries, and not related to immunocompromising conditions, as we already have in place now, but rather this booster qualification we hear may be based on months since you got your first vaccine series. And the number that we've heard is 8 months. And so what does that mean? It means that those healthcare workers or those educators, those really, I would say critical workers for infrastructure who were already receiving their vaccines back last December, January, February, and March would be again either at or approaching that 8-month cutoff, and could anticipate that if what we've heard last night, unofficially, but if what we heard last night in the media reports does come to fruition in the next couple of weeks, there may be a big national shift in policy regarding booster vaccinations, whereby our public health agencies do make a recommendation that people who have been 8 months since they completed their vaccine series may well be recommended to get a booster dose. And so I don't think I have much more to say on the current boosters, but that's really the lay of the land with regards to that. The root of the question, I think, is actually more subtle and more important. And I just want to make sure I really, really clearly answer the question. Everything I've said up till now is basically using more of what we already have. We've got the vaccines, they're working pretty well. For some people, maybe they'd keep working well or work for longer if we give more. There's a second question, which is, should we be anticipating that at some point we'll be using something different? And that's a very, very good question. The nature of this pandemic has been that variants have come and gone. And there's always an advantage to a new, more infectious variant getting a hold of our global community. But also it makes sense that with really just evolution and replication of this virus, that we eventually are going to see perhaps some pressure for a virus that could develop that may make its way around the current vaccines that we have. I'm not talking about small numbers of breakthrough infections, but really potentially a variant that could develop that would really render what we currently are using as no longer effective. I hope that that never happens. However, I think it is something that is squarely on our minds and something that we need to be prepared for. The really good news is that with mRNA technology, with this really incredible advancement in the way that we can now make and develop and use vaccines, we have the ability very quickly to pivot if or when we need to. I'm not saying that we'd be able to produce 1 billion new variant vaccines overnight with a snap of my fingers, but compared to the old days of 10, 15 years of vaccine development, the fact that we could very quickly adjust and very quickly manufacture a safe and effective vaccine that was targeted to a new variant, I think is very empowering and very reassuring. So hopefully that helps answer the question. Does that make sense, Diana?
It does. And I think as an add-on question to that, when you talk about vaccinations and timing for them to be safe enough to start giving out to the public, Where are we as far as a timeline for getting vaccinations available for kids under 12? Are we getting any closer to seeing that come to fruition, or is that still a ways out?
The latest that I've seen within the infectious disease communications has been December as a goal.
Oh,
I think that we all are getting opinions and information from different sources. I think it's disappointing that early last spring we were optimistic that it could even be the case that we were looking at September. And I think, again, we obviously don't have one ready for September. I'm optimistic, though, that in these coming next, few months, things are moving quickly, and hopefully that'll be around the corner. It's pretty clear, though, that we're obviously, and I'm preaching to the choir here, talking to you all, but we're obviously starting the school year without that tool in our tool belt. And that's why we're having to reach for these other tools.
Okay, thank you. I do have a couple of questions here that came up that I want to try, and a couple of them are the same. So in your role as an infectious disease specialist, and you're in lots of conversations with Santa Barbara Public Health Department, obviously Centers for Disease Control and our California Department of Public Health, all of these folks are providing, the direction for us as a state and how to conduct our business. And I think that, often there's some differences in understanding the mandate versus, a recommendation. Currently, our mandate for the state is indoor masking. And so we will obviously, as a district, follow that mandate. I think that, even in the meeting I just came out of about discussing transmission outdoors, what I'm hearing is that transmission outdoors is less prevalent indoors, which is my assumption as to why we're not having the outdoor mask mandate. Do you see or anticipate that if things don't improve and we are continuing to see an increase, that these organizations may switch and mandate to an outdoor mask? Or, what are your thoughts on that? And it probably varies from state to state, county to county, but what's your take on what you're hearing from the medical experts in that area?
Thanks. It's a really good question. Just to set the stage, I talked to a lot of people about a lot of this stuff, and one kind of emotion that I've heard a lot of is frustration at things changing, at the recommendations changing. And I was on another meeting actually earlier today where I had the opportunity to voice, my gratitude actually for our public health officials and leadership in education, in the healthcare sector, in every one of these other spaces, to be able to actually pivot as we learn new information. And so as upsetting as it is to not feel that you have concrete, I think, foundations that are, that are what they are going to be for this entire year, I wish that today I knew what we were going to know next June of 2022. That would be wonderful. In which case we would, spray paint the rules on the wall. We would, get a plaque, and we would say that these are absolutely the truths. The problem with this pandemic is it's been very dynamic. Mm-hmm. And so I actually, see it perhaps from a different angle, that I am so grateful that we have the ability to adjust as we need to. Yeah. Which doesn't mean it's not disruptive. In healthcare, sure. My world's healthcare, your world's education. In healthcare, it's remarkably disruptive when we have to change the policy for 5,000 employees and physicians. Mm-hmm. But it's important that we stay nimble and do it.
Sure.
So then getting to the specific question of outdoor masks, I think this is clearly a good example of this. Mm-hmm. What we know is that when you share the breath, the space, the air between two people, one who's infected and one who's not infected, we know that there's the possibility for the infection to be transmitted. Mm-hmm. We also know that sharing that air happens much more commonly in an indoor space. We know that the better ventilated that indoor space is, the lower the risk. And we also know that in the outdoor environment, if I got a classroom of 20 first graders and had them all sit literally shoulder to shoulder in an outdoor space for a long time, they would be sharing the same air. And so even though by nature it's an outdoor space, if there's kind of a child or a person who's quite kind of stagnant, sedentary, just sitting in one location without kind of movement, essentially ventilation, then we know that that risk is going to be higher. We also know that running around a playground, some kids cluster, some kids never stop running, and the kids who never stop running need to never stop running, because that is
safest thing to do.
Right?
Yeah.
I'm preaching to the choir. You guys know this. And then to weigh all this against the final consideration in, making these policies this isn't something that's going to end next week. Mm-hmm. This is a large fraction of our children's lives at this point. Mm-hmm. And again, I know I'm speaking to the experts here, but weighing what we truly know about the risk of this infection against the effects this is having on our children's development, in not seeing faces, in not seeing the smiles and not seeing the frowns. I think that's all the background to the recommendations as they stand.
Sure.
Again, I've said this last week, and my opinion hasn't changed. I feel very strongly that I want my children, their classmates and teachers wearing masks inside the classroom. I think that keeps all the fantastic teachers safe. I think it keeps the classroom safe, and with the mandatory quarantine opportunity that we have, where the whole class doesn't have to shut down with a positive case, but rather, maybe only those who had more intimate unmasked contact. I think that all of these are good reasons to really keep masks on indoors. I worry that if my children live a large part of their lives with their masks on, not seeing faces, I worry that that's going to not be positive in the long run. And so I love the idea of my children running around a playground, hopefully not sharing air with other people, but without a mask on when they want that to be the case. And then even if they're outdoors, when they're back in kind of a setting where they're, again, more shoulder to shoulder and closer to other people, I would appreciate them having their masks on. That's my personal feeling as a parent and an ID doc. I think it's possible within the next few weeks that we, get a change in guidance on this. I think that ultimately, if you are working with parents who feel very strongly that they want their children to be masked outdoors, then they absolutely should be. And I'm very supportive of that. And I actually would definitely recommend that, we maintain ways to make that as easy for children as possible. Does that kind of
Absolutely. Yeah, no, that's great. Thank you. And I'll answer a couple of these questions. There was a question about staff being vaccinated, and if we are requiring that. Yes, as a state, as an entire state, that is a mandate that our educators are vaccinated. And I'm happy to say that we are currently at over 90%. We have just contracted with Aptitude, and starting today, all of our employees, before they return to work, have to provide that negative test. And even since we implemented that mandate that came down from the state, we have had a large number of vaccination cards come in just in the last few days. I want to say 58. And so we are seeing a continued increase in our vaccination. So we are super proud of that. And we also have a plan that's in place as of today for testing our unvaccinated employees to make sure that they are negative before they come to work. So we are working diligently on that. And I absolutely agree. We will always follow our mandates and provide opportunity for families and children to get a mask break outside, to run around, to encourage that active play and social interaction. However, we also honor the fact that some families may choose to have their children wear masks outside, and we don't ever want to discourage that. We will always encourage that, and we will stay nimble, and we will easily pivot as we need to. So I appreciate all of that. We did have a question about transmission for a parent to a child. So let me get to that question. It says, if vaccinated adults are asymptomatic, how transmissible is the COVID Delta variant to my unvaccinated child?
Good question. So asymptomatic infection is a tricky one, in part because it's very hard to study, because it's hard to know when it starts and when the infection actually occurred. But having said that, let's say someone knew they had an exposure, became test positive, but did not have any symptoms. We do think that those cases probably have lower viral loads or a lower amount of infectious virus than people who are more symptomatic. And what we know with the Delta variant is that, of course, everyone is really developing higher amount of virus than with any of the prior variants that we've seen, vaccinated or not. There's one really, really cool piece of data that I reviewed this morning that I can share, which is related to, again, exactly this question. So if I can kind of paraphrase the question, my understanding of the question is really getting to the crux of how infectious is a vaccinated person, asymptomatic or not. And there's some great information that came out of Singapore. It's pre-publication, so it'll get peer reviewed and hopefully published, but it's available for review in the raw form right now. And what it showed is that just like in the Provincetown outbreak in Massachusetts that we heard about 3 weeks ago, both unvaccinated people with infection and people who had breakthrough infections after vaccination, they both had really high viral load. What we learned from the Singapore data is that, yeah, that's true at the beginning. But then what happens is the unvaccinated people tend to keep having high viral loads for a very long time, for a large number of days. We think they're infectious for, up to perhaps 10 days. What happened to the people who had breakthrough infections who were vaccinated? Yeah, at the beginning, they had high amount of virus, but it very quickly dropped down. And so this is a long-winded way of saying, as a vaccinated parent, if you become infected, whether asymptomatic or symptomatic, unfortunately, you may well be infectious. But the good news is there's at least some early data that says you probably aren't as infectious as long as someone who's unvaccinated. And I'm really confident that we're going to see more and more studies kind of confirm this. So more to come on this.
Okay. I've got another question that says, how should we handle vaccinated extended family seeing our children indoors? Should we keep these visitors outdoors even if they are vaccinated?
So I would defer to the public health department for their guidance on this. I think the general recommendation is when you're indoors right now with people outside of your household that you ought to be wearing a mask. I'm also happy, again, as you mentioned, Diana, I'm speaking a little bit with my infectious disease hat on, but I'll take it off for a second and I'll just speak as a parent in your district. And I'm happy to share what our family has chosen to do. So we really, as Delta started to surge about 3 or 4 weeks ago, we really did start to transition, as much as possible, our activities together to being outdoors with extended family, grandparents and such. I think going forward, would I say that that I would keep my child and a grandparent out of the car with one another? Of course not. I mean, we have to do what we have to do. But would, for short trips around town, for example, I perhaps suggest that if they're going to be in the car together for 5 or 10 minutes, that maybe they both wear a mask? I might, because I just think that might be the safest approach.
Okay. We have a question specifically about masks. This person is asking if a child-sized KN95 mask is truly better than a cloth reusable mask. This person is stating that the KN95 mask for their child makes it difficult for them to breathe. So is there a preference? I mean, is wearing a simple cloth mask because it's easier for their child, is there really a health risk if they were to choose that route versus a KN95 mask?
So it's the devil's in the details with regards to the fit. So the KN95 mask, let me see if I don't have any KN95s, but I have 2 of these.
Okay.
So, sorry. So here we have a plain surgical mask, which again fits like this, and I make sure it fits me nice and tight. I make sure I pinch my nose, and I've got a pretty good fit here. So this is providing me a good amount of protection. I'd feel very comfortable for my kids to be in school with a mask that fit this well.
Okay.
Now I'm well aware that a lot of times my son walks around like this, and I remind him to put it up like this. But at the end of the day, if it's fitting well, a mask like this or a multi-ply, so 3-ply ideally cloth mask is going to give you a fair amount of protection if it's fitting well and over the nose as it should be. The KN95 is more, this is an N95, but it's more similar to this, where it's very tight fitting. And it's designed to keep out 95% of all of the aerosols. And so again, in healthcare, we actually have very strict laws around this, Cal OSHA laws, where we have to actually have every single person who's going to wear one of these. We have to have them fit tested with a very specific set of criteria. It's a big training, a big deal. The problem with purchasing something like a K95 and then putting it on is, it might be that it's a little bit too loose, or it might be that there are vulnerabilities in it. And so I can't say for sure that, a tight-fitting mask is definitely going to be more protection. But as a general principle, that is the case. Having said that, as someone who's worked in the COVID unit for months and months, year and a half, I don't know that if I was attending school that I would be able to tolerate such a tight-fitting mask all day, every single day, really long term. And so I think that a very reasonable compromise is, again, the well-fitting, either multi-ply cloth mask or something that's more medical grade with regards to a surgical mask like this, if it fit well.
Okay. And there is a question about warning immunity from vaccines. So let me just read it. For the warning immunity from vaccines, is it just leading to more breakthrough infection, or are those breakthrough infections going to be severe? As of now, the vaccines are protecting against severe illness. If there is a breakthrough infection, are boosters being recommended, because that's not going to be the case a year after the vaccine? I feel like you kind of addressed that already earlier.
I did, and I can add to it just what we know from Israel is a really good example is that even I think the answer is the first. And so what I mean by that is the waning immunity that we're getting is making breakthrough infections more common, but it's still mild and moderate infections. They're still, in the Israeli data, they're still seeing very, very good levels of protection against severe and life-threatening COVID. So, I think the root of the question is, okay, so I'm telling you that in a couple of weeks' time, there might be the opportunity to get a booster vaccine, but should you? And I think those are good questions to ask. As of right now, again, I feel very confident that the vaccine series that anyone has received in these last 8, 9, 10 months, 8 or 9 months, I suppose, is giving you still very, very good protection against severe disease and hospitalization.
Okay. Great, thank you. And then there's a question that says, while kids and staff should not come to school sick or within 24 hours of needing medication to reduce the fever, what is the advice about people with allergic or other chronic conditions that result in coughing and or sneezing?
So I would defer again to the public health department and the school nurse leadership who is working so closely to develop protocols on this for any specific cases. I can say more generally that with the Delta variant, we are seeing more in the way of kind of allergic type symptoms. And so I think if someone has had an exposure, some travel, or has some reason to believe that they may have been infected with COVID, and they do develop just a little runny nose or a little more allergic type symptoms, it's probably allergies, but I would recommend that you speak to your healthcare provider and strongly consider getting tested for COVID.
Okay. And along the lines of testing, I know there's a lot of, question with regards to surveillance testing. And so as a parent and as families think about that choice for themselves and their children, what recommendations would you have for families as they consider, because they can certainly surveillance test their children. I know surveillance test kits are easily available at, local pharmacies. What would be some input or thought, like what's being discussed from a more universal approach in our county as far as testing children specifically? Because I know that that's not currently a mandate, but what are some conversations, and what can parents do should they choose to do that for themselves and their children?
So I think, again, we've worked a lot on this in healthcare over the last last year, really, since surveillance testing was first a mandate to be offered to healthcare workers. I think it was August of last year, actually. And so we put, in healthcare, we have had the opportunity for people to get surveillance testing. And so the thing to remember about surveillance testing is, if it is not everybody, then you're really undergoing the surveillance testing, of course, only for the benefit of the individual being tested and the people immediately around them. I can just give some anecdotes of healthcare workers who have continued to want to do surveillance testing versus those who haven't. There are healthcare workers who just feel more peace of mind going home to their family, their partner on chemotherapy, visiting with the in-laws, if they undergo the weekly surveillance testing. And so they've continued to do that, again, as an assurance. There are people who I think, don't necessarily see the benefit because they don't see themselves as necessarily being exposed. And again, without having a position one way or the other, or whether we should all be doing it, I will simply say that unless everyone is being tested and undergoing surveillance testing, the benefits are truly really only those of the person being tested and their immediate family. And so that's why I think it's really an individual choice for people right now. If ultimately it really assures you and your family to know that, with some frequency, people are negative, then I would encourage it. But do remember that there's always the possibility of false positives. We think they're infrequent right now as the prevalence is so high, but that's a possibility. And do think through exactly why you're doing it and, making sure that it's the right choice for your family.
Okay. And I know you need to wrap up by 12:45. So I'm going to end with this last question and any closing remarks that you would like to share. If there is a situation where, this question came in pretty early, and it's a person who said they experienced an abnormal adverse reaction after their first vaccination dose. So they were unable to get their second vaccine based on doctor's recommendations, since this person was sick for 3 months after receiving the vaccination. This person is nervous about having their own kids vaccinated because of this response. Are top health officials aware of abnormal adverse reactions occurring in our community and monitoring them? We need reassurance that our vaccines will be safe for our kids. So we'll close with that question and any other closing comments.
Sure. Thanks, Dana. That's a great question. So the answer is yes. The data is being aggregated. I have, had cases where someone came in with a medical problem. They had the vaccine recently. I don't know if they're related, but I report it. And, I think we're all doing that. It's a pretty easy process. I've actually had then responses from the CDC saying, and, they just know I'm someone submitting a report, but then a response back asking for more information and have been, able to give that. So I'm pretty confident that the process is working well. It's also the source of a lot of the data when we've had these emergency ACIP meetings to review things like the thrombotic thrombocytopenia that we had with Johnson & Johnson, the pericarditis, myocarditis that we had with the mRNA vaccines, and then the Guillain-Barré question with Johnson & Johnson. And so it's that data, it's that aggregation of data that they're relying on to review. For this person though, what I would remind you is that the aggregated data is one thing. The right approach for you and people who are genetically related to you is a different question. And so I think starting with your own physician as you did was just perfect. The second is actually getting either your own physician, or if you work with an allergist or have the opportunity to work with an allergist, the opinion of someone who could review exactly what your reaction was and the likelihood that this was a hypersensitivity reaction, a type of hypersensitivity reaction that may in fact run in your family, something that, again, it could be something that was truly out of the blue and isolated and unlikely to be something that tendency shared with your offspring. But the question's a good one. And I would, if it was me in that position, I would talk it over with my primary care provider. And then I would wonder about maybe talking to an allergy specialist to say, hey, can we review what happened to me with this reaction? I'm not planning to get the second dose for myself because of the concern of potentiating that first reaction. I don't want that to happen again. But, can you give me any guidance on the likelihood of, of my kids sharing that reaction? And, maybe I think it's unlikely that anyone can give you full certainty as to what your children's own reactions are going to be, but there may be more to your reaction that an allergist could tease out and help you understand whether or not this is, again, something that likely runs in your family or not. So I think that's probably what I would do if I was in that position.
Great. Thank you. Any closing comments?
Just thanks. I think that you will all look back on this start to school as a once in a lifetime start to school. I know how hard Diana and her team are working. I also know how incredibly hard every single staff and teacher in our district is working. But I also know that you have thousands of kids that are dying to see you tomorrow. And just know, I think some of us, have opportunities to speak in a forum like this. Some of us make public comments in board meetings, and some of us really, I think, are quiet and in the background. But please just remember that behind every one of those thousands of smiling faces tomorrow are houses just bulging with people who are grateful for everything that you guys are doing. These next few weeks might be a bit bumpy. There might be some cases and there might be some illness, and I hope that's not the case. But I'm very confident that I think everything is pointing in a really, really good direction now, and I'm really grateful for that.
Thank you, Lynn. Thank you for being so accessible and supportive and supporting not only us as a district, but also all the different local agencies who appreciate your support as well. And parents who joined us, thank you again. Please know that we are trying to be as responsive as possible, but also preparing the best school experience for your kids and balancing everything out. We want to make sure this school year is remarkable for your children, that it's safe for them, that they can learn and thrive, and that we can manage this all in an environment that still stays positive for learning for kids. So thanks again for joining us. Like I said, this is recorded. We will provide Spanish subtitles, and we will get this posted on our website so other families who were not able to join us live today can access the information. And Dr. Fitzgibbons, again, thank you so much for your support. All right, everyone have a great day. Thank you.